Our speaker is Dr. Claudia Guida, who is the director of the section of heart failure, transplant, and mechanical circulatory support in Newark Beth Israel program. And we are honored to have you over here in person. So the grand round is being done in our conference room with online projection. Just going through the logistics, this is going to be recorded and available on YouTube, and you see the YouTube link on the screen. Also, if you want to apply for CME credit, please follow the on-screen instructions. You will have to text 25687 to this number that you see on the screen, and it has to occur within 12 hours after the session. And you can text as a SMS message, not an iMessage. And you must have an active profile in Rutgers Cloud CME platform if you want to get credited in terms of continuous medical education. And your mobile number must match the phone number provided in the mobile phone field of your profile. Also, for physicians who want to use this for maintenance of certification, you have to complete step 2 and also to answer a brief quiz at the website that you see on the screen. And you can use the room code of Future 2025 with the same eligibility requirements. You see the combined instructions for CME credit or information of certification, and you have to scan this barcode that you see at the right lower corner of the screen, which says "Scan Me." So with this introduction of the logistics, I want to introduce Dr. Gideon. And she has remarkable contributions to the field of heart failure and heart transplant. Claudia is originally from Romania. She finished medical school and residency over there, after which she moved to the United States, and she joined the research fellowship here at Rutgers University. It was 94-95. She did her internship and residency in this country in 1997 to 2000, and this was at University of Illinois in Chicago. And then she completed her cardiology fellowship at University of Wisconsin, and then she was trained in advanced heart failure and heart transplant. So she is board certified in all possible branches of cardiology you can imagine, including echocardiography, nuclear cardiography, the transplant, LVADs, advanced heart failure, and so on and so forth. She started her professional career in Chicago at Michael Reese Hospital, where she was Associate Director for Echocardiography and Associate Program Director for Cardiovascular Fellowship. Then she worked at Rush University Medical Center in Chicago as Assistant Professor of Medicine and Director of Pulmonary Hypertension and Vascular in the Department of Cardiology. After which she moved to New Jersey, and after this she worked at various institutions as a faculty in Newark Beth Israel, at NYU, at Mount Sinai, and back to Newark Beth Israel. Dr. Gide published multiple works in the area of transplant, mechanical circulatory support, and cardiogenic shock. She is the editor of Frontier in Transplantation. She regularly moderates sessions at ISHLT, and she is overall a well-known professional and expert in the area of heart failure, cardiogenic shock, mechanical circulatory support, and cardiac transplantation. So we welcome you to our medical center. We're happy to have you here. And I will pass the mic on to you so that you can present your topic, focusing on surveillance post-cardiac transplantation.
Thank you so much for so kind introduction, and it's an honor for me to be present here and to discuss at cardiological rounds about advances in heart transplantation. I do not have any disclosure for this talk, and the objective is to understand the role of non-invasive screening and diagnostic strategies for transplanted heart acute rejection, to consider if artificial intelligence is a prime time in heart transplantation, and for the last slide, I'm going to talk about donation after circulatory death as a key strategy for expanding the donor pool. We know so more than 150,000 of patients have advanced heart failure stage D. There are need for advanced heart failure therapy like durable LVAD, heart transplantation, and we don't have to forget that palliative care is a therapy for advanced heart failure. But I think talking of durable LVAD and heart transplantation, two inflection points in time made these advanced heart failure therapies somehow unique. Considering durable LVAD, in June 2021, FDA withdrew from the market the HVAD. So as a consequence, we are left with HARMATE-3, the only available 11 classes device in the market, which is a monopoly. In heart transplantation, everybody is aware, in 2018, a new allocation system was started, and this had implication in terms of the number of transplants and the number of beds. HARMATE is the monopoly. Now we have a new pump that has to be studied in the United States. It's a pump which was built in China. It's in feasibility trial right now. It has the same kind of structure, a truly magnetically levitated pump, but a smaller drive line with less prone of infection. But if in durable LVAD you don't have too much continuity and too much advances, in heart transplantation for the last 10 years, we have a lot, like hepatitis C donation, now DCD donation with normothermic regimen perfusion and direct procurement perfusion. And of course, we saw the data for xenotransplantation, which particularly now are very more in kidney than in heart. So when we think about heart transplant success, we think about very careful recipient selection, a very careful donor matching with the recipient, and of course the surgery has to go very well. Immediate post-operative care and short-term care are important. If you think about immunosuppression, this is the vulnerable period immediately when a lot of immunosuppression therapy is delivered to the patient. And therefore, the infection prophylaxis is very important in order to decrease the infection burden. But rejections are still 20 to 50% in the first year present, both acute cellular rejection and antibody-mediated rejection. When you think about long-term, like more than 1 year and more than 5 years, cardiac allograft vasculopathy is very important, it's 30% at 5 years. Malignancy and opportunistic infection. So the majority of rejections are occurring in the first month to 6 months post-transplant. And still at this moment, the gold standard for rejection is the myocardial biopsy, which is an invasive procedure. And it's prone to sampling errors because most of the biopsy is going to the septum. If it's going to be oriented towards the RV free well, there is complications like rupture and tamponade and something like that. And interobservable variability in terms of pathology reading, and particularly this variability is seen in acute cellular rejection. Overall, the complications are 6%, like tricuspid valve damage with severe tricuspid regurgitation, site entrance hematoma, arrhythmias, and so forth. So what is the tendency and what is the heart failure world trying to do? Trying to move the gold standard from the invasive right ventricular endomyocardial biopsy to non-invasive testing. And we have blood testing and imaging testing. Imaging testing like echocardiogram, and now we added global longitudinal strain, and cardiac MRI. And both of these modalities, like screening for acute rejection, are making the guidelines as class 2B level of evidence C. In transplantation, you don't have like for STEMI, randomized controlled trial with thousands of patients. Therefore, if you look at the guidelines, only few indications are class 1, most of them are class 2A and 2B, with no level of evidence A, most of them is level of evidence B and C. In terms of blood testing, we have proBNP and high sensitivity troponin, also a class 2B level of evidence C in the guidelines. But what is now emanating in the world of screening for acute rejection is gene expression profile and donor-derived free cell DNA. And both of these combined under AlloMap and AlloSure are delivered by CardiX company. Prospera through Natera are delivering donor-derived cell-free DNA. So we have this kind of tools that we can see in the next couple of slides. How can we manage them to replace the gold standard of myocardial biopsy? So when we talk about rejections, we talk about surveillance, and we talk about evaluation for rejection. And surveillance means, you are asymptomatic, and you want to see if the patient is going to have rejection in order to be treated accordingly. In terms of evaluation for rejection, the patient has symptoms, is in heart failure, the ejection fraction decreased compared to a previous echo, and the right heart hemodynamics are showing high filling pressures. At that moment, probably you should biopsy these patients in order to confirm rejection. This is how we move, through this biopsy versus non-invasive testing, and this is only for surveillance. Because if you don't have symptoms, then you have to get a biopsy. So gene expression development was starting in 2005. And this slide, when I presented first time, it was 10 years history. Now we have 20 years history with the gene expression profile. And through database and machine learning from a huge genes that are associated with rejection, we came down to only 11. And some of them are overexpressed, some of them are underexpressed. And again, by mathematical data and formulas, we combine all these gene expressions more or less in numbers. And AlloMap threshold early post-transplant, between 2 and 6 months post-transplant, it's abnormal if it's more than 30. More than 6 months, it's abnormal, it's more than 34. Just to clarify, this is a binary testing. It has a high negative predictive value, and if it's positive, it's positive for high-grade rejection, not for low-grade rejection. These are the trials, and I'm not going to go through them. What I want to mention also is the outcome of the AlloMap registry, which is a registry, so it's not a controlled trial, so it's all in camera, it's real life. The data are collecting from 2013 to 2017, and you can see the negative predictive value at 2 to 6 months is 98.4%, and more than 6 months, the negative predictive value for a score of less than 34 is 98.5%. And you have some kind of limitations of the use of gene expression profile, because being an immunoassay, with looking at the genes that are coding for rejection. You cannot have a high prednisone dose. Some of these genes are prednisone-related genes and are decreased in rejection. CMV infection can affect your gene expression profile, and also if we look, the new data shows that administration of Mupogen also is related with an abnormal gene expression profile. We go back in 2011, the gene expression profile made the guidelines as a class 2A indication, level of evidence B, for screening for acute rejection more than 6 months post-transplant. In 2021, we have new guidelines, and the new guidelines move the gene expression profile with the same class 2A level of evidence B, but now we can use this test much earlier post-transplant at a starting of 55 days based on the e-image trial. What about cell-free DNA? In our body, we have cell-free DNA from our own cells. And the cell-free DNA copies varies from 10,000 copies per ml to like 100 billion, depends of turnover of the cells. And the idea of donor-derived cell-free DNA didn't come from solid organ transplantation, came from cancer. But what was noticed that due to any injury of the organ transplant, like rejection, like cardiac allogravasculopathy, like reperfusion injury, you are going to have delivering heart donor cell-free DNA. And it's a complicated genomic measurement with this DNA through single nucleotide polymorphism, and we calculate the fraction of the cell-free, donor-derived cell-free DNA versus the host cell-free DNA. But what is this ratio, right? Because people are going to try to move away from the ratio. If I have one donor cell-free DNA and 5 host cell-free DNA, the ratio is 1 to 5. If I have 2, donor-derived cell-free DNA and 10 host cell-free DNA, the ratio is the same. But it's the number, the absolute quantitative number of donor-derived cell-free DNA important in prognostication and association with graft dysfunction. And now Prospera is looking at this. They are actually reporting the amount of donor-derived cell-free DNA, not only the ratio. And just to verify very clearly, the ratio differs between the two companies. There are many studies done with donor cell-free DNA in heart transplantation. This is not only heart transplant, but what was noticed that the occurrence of donor cell-free DNA precedes histological rejection by at least 3 months, 120 days. And these are all the studies that we've done, but I'm going to focus on 2. The first one is the outcome AlloMap registry that involves 26 centers in the United States and look at both gene expression profiles and donor-derived cell-free DNA through CARDX. And through this registry, the threshold of 0.2 of the ratio was considered to have a negative predictive value of 97%. But when they look at a cohort of patients, and in this particular registry, 33 patients that had the histologic diagnosis of antibody-mediated rejection, the donor cell-free DNA was 3 times higher than in patients with no rejection. The other thing I want to focus is the surveillance healthcare outcome registry, or SHORE, which including 27 centers from 2018 to 2024. And this is just came out from Journal of Heart Lung Transplantation. These are data from this SHORE registry showing that if we are combining both AlloSure of AlloMap then maybe the number of biopsies are gonna decrease. And just to give, an idea about this shore registry, they have a lot of centers involved now, 67 transplant centers, and they have around 3,000 transplanted patients with a high number of biopsies. And the idea here is to have two pathways. It was done in the past on the same day biopsy surveillance to send blood for gene expression profile and donor cell-free DNA. In other words, we correlate histology right away with the blood testing. But now we move away from this, and we do the blood testing after 2 months. And sometimes I'm starting AlloSure at 2 weeks post-transplant, particularly in the patients who are very sick and cannot go to the biopsy. And if this is of concern, then at 14 days, between 2 and 14 days, is triggering a biopsy. And what are the data? If both AlloSure and AlloMap is negative, then the percentage of rejection, acute cellular rejection, they look only, they didn't look at the AMR yet, it's 1.5%. So these patients are not worth to go for a biopsy. If you have AlloMap positive or gene expression profile and AlloSure negative, your ACR is still low, 1.9%. So also these patients should have maybe an AlloMap checked in 2 weeks, or don't go to biopsy, maybe just improve the immunosuppression. But AlloSure is positive, and AlloSure has another significance because it's a marker of organ injury. You can see that the incidence of acute cellular rejection increased by 4-fold. And if both of them are positive, it's 9.2% incidence of ACR. How you place this in perspective with the likelihood positive ratio for acute cellular rejection? If both testings are positive, your likelihood to have rejection is 3.9 with a specificity of 92%. If you have only AlloMap positive, it's only 1.4, and if you have AlloSure positive, it's closer to dual positive testing at 2.9. Translating this in the number of biopsies in the first years, looking from 2018 to 2021, is a decrease by 10% of the RV biopsies. But if you look at the second year, it's a dramatic decrease by 40%. And if we look, can I have the, if we look, timeline from 2019 to 2022, we have a linear decrease on the number of biopsies if both testings are negative. We have a dramatic decrease in the number of biopsies if only gene expression profile is positive, and you have also a decrease on the number of biopsies if the AlloSure is positive only. But if both testings are positive, you are not shy to biopsy these patients because you are going to find something with a likelihood ratio of 9%. And if we translate this in outcomes, we can see that at 6 months and 2 years, the likelihood of having graft dysfunction and mortality is higher if you have dual positivity compared with no dual positive. And again, these are verified by biopsies. But what was presented at, this is the NPI protocol that I developed when I was at NYU and I updated with MMDx when I came to NPI. So it's very self-explanatory. It's positive, you do a biopsy. If you have a negative AlloMap and you have a positive AlloSure, I'm obtaining the transthoracic echo and I'm obtaining DSA. And if there is increase in LV wall thickness and I have systolic dysfunction, abnormal globulation strain, now incorporated globulation strain in all our transplant patients, and the DSA more than 5,000, then I'm going to go probably the biopsy plus MMDx. So this was presented at the ISHLT last month, and these are from the Shore registry also. And these are pertain on the population that is biopsy negative. And if you have a dual testing positive with a negative biopsy, and you look at the timeline, you are going to have a worse outcome than if the patient have a negative biopsy with a dual testing negative. So in other words, in this biopsy negative substrate of patients, dual positivity has worse outcomes. So what we are doing next, should we treat this positive? Should we do a biopsy and look at AMR? What really we should do? So these are very intriguing data. We should think these are biopsy negative rejection, is such a thing. So these are very intriguing data, but definitely in this moment, the non-invasive testing have prognostic significance in patients who have a biopsy that is not positive. So conclusion on this, heart care combines gene expression profile and donor-derived cell-free DNA for surveillance of acute rejection. Dual negative results strongly correlate to the absence of significant rejection. Dual positive results have worse outcomes even when routine endomyocardial biopsy is negative. And now we are transitioning probably to a new gold standard, an integrated, mostly biomarker-driven approach where biopsy might be one of the complementary tools. Looking at the evaluation of rejection when the patient has symptoms. And again, we have to understand this RV biopsy negative rejection or DSA, donor-specific antibody negative antibody-mediated rejection. And when I have an antibody-mediated rejection by histology or by molecular microscopy, and my DSAs are negative, I think of non-HLA DSA AMR. So as I mentioned before, RV endomyocardial biopsy has its pitfalls, inter-observer variability. Most of the time, maybe these rejections are not uniform, so you can take patchy pieces of the myocardium, and they can be negative. And now this is supplemented with what we call molecular microscope diagnostic system. And what is this? This is using the wide genome array. You take the biopsy, usually take one piece, now we are moving to two pieces, and you place these pieces of the myocardium in a solution, and this solution is degrading the enzyme that degrades the RNA. In other words, this solution stabilizes the RNA. We place this myocardial biopsy in a container that is provided by the company, and it's shipped at the room temperature and can stay in the container for 7 days. And then what you are doing, you extract the RNA from the tissue, you label this RNA, and then together with oligonucleotides up to 500,000 that are combined together in some kind of probes, you are looking at the expression of this kind of almost 20,000 genes that are correlated with rejection. From machine learning, you place this in the software. It's like a chip, you can see it. And then you quantify the expression of the genes the same as you quantify MFI in donor-specific antibodies. The more they express the gene is, the more gonna be, predictive for a particular rejection for which that particular gene is associated with. This is how we receive now the report. These are two components, primary component analysis, 1 and 2, and 2 and 3. You read this from right to left, and this is from up to bottom, and by different colors. Gray is no rejection, this dark blue is antibody-mediated rejection, the light blue is injury, and the red is T-cell-mediated rejection. But what we are doing here, we are actually combining rejections with injury. And when this started first time from Canada in kidney biopsies, we used to say that, oh, injury is not rejection, it's fine, it's just injury. But people understand now that it's not fine if you have injury, and we have to correlate the association of injury with rejection. And there are also particular genes that are induced, like interferon gamma, in not only one particular rejection, but in T-cell, antibody-mediated, and injury. So how we separate this assessment of rejection and injury extent? Of course, through the machine learning, right? And usually in MMDx, you use more unsupervised learning than supervised learning. In supervised learning, you draw predictive models. You place in the training machine label data, and this training machine is dividing this label data by the characteristics and the association. And then if you place the unlabeled data, the machine knows where to place this unlabeled data. In unsupervised training, you place practically unlabeled data. You don't know what you place. But because of similarity and because by clustering, these data are going to be clustered in different archetypes. And this is how the archetypes analysis is coming in this MMDx. The principal component analysis that is important in reading this rejection and injury are coming that you have to place in this machine learning big data, a lot of data, but you have to reduce them because you cannot interpret everything. And by this dimensionality reduction, you are going with this principal component. Unsupervised learning deals with pattern recognition, does not deal with predictive models. So how we are understanding this in moving forward? Before moving forward, we have to understand what means disease-associated and disease-selective. Disease-associated means genes that are associated, and I'll give an example, ABMR can be T-cell medical rejection. By applying an algorithm, you distinguish these rejections from normal tissue. But we know that sometimes we have multiple rejections, type of rejection, and injury. So how we do disease selectivity by distinguish different types of abnormal? By identifying gene expressions only for ABMR versus other genes that are coding from TCMR or injury. And this is how the machine is taught to distinguish its ABMR versus everything else. This is the classifier and the genes that we are receiving now in the first generation of MMDx. And you can see that this gene expression, they are under the normal limit, and the interpretation it's normal, so we don't have any rejections or any injury in this particular patient. So why we are interested in injury? Because injury comes from different causes. In the brain death donors, you have this catecholamine surge, and myocardial injury starts in the donor body of the heart that you want to harvest and to take for transplant. This heart is placed in preservation solution, and it also can cause myocardial injury. And when the heart starts to beat in the recipient chest and reperfuse, this also can be associated with reperfusion injuries. And all of these three are associated with these recent injury patterns that I'm going to talk about. But also any rejection, it's associated with myocardial injury, right? Rejections are myocyte destruction and release of C-free DNA. Infections like CMV, myocarditis, can be associated with myocardial injury. And let's not forget about cardiac allograft vasculopathy that can give ischemia with the same kind of concept of release of cell-free DNA with myocyte apoptosis as in atherosclerotic ischemia. Even the mechanism of cardiac allograft vasculopathy is immune-mediated with intima media thickness and is diffuse luminal narrowing, which is different than the focal narrowing as is in atherosclerosis. So this is a study that came out and was very popularized at ISHLT when 3,000 heart biopsies were placed in the machine learning in order to develop a second generation of MMDx reports differentiating parenchymal injury and rejection. And instead to use rejection-associated transcripts, they use classifiers from kidney rejection. And I'm not going to go through this, but what I would like to give the attention here, that the algorithm they applied is ABMR versus everything else, BCMR versus everything else, all rejections, mixed, AT versus everything else, and they use this binary classifier, LV ejection fraction less than 55 versus more than 55. And you can see here the training features were histological data. So in order to increase the data that are inputted in the machine learning from InterHeart trials that look at the first generation MMDx, they took 1,500 biopsies almost, that they have histological assessment. So each of these biopsies had MMDx, or molecular microscopy diagnosis, and they're associated with their histological assessment. But we sent our MMDx to a Kashi laboratory, which is based on Rhode Island, and it's a miniature laboratory compared to the one in Alberta. And when I sent the biopsies that they have to extract the RNA, Kashi laboratory doesn't know the result of my histology, right? So they combine like real-world biopsies with the one in the trial, and they come to this higher number instead of 1,400, 500, 1,500 to 3,000. And then placed based on the machine learning here and using as input these 6 kidney classifiers, they figure out 7 archetypes for rejection. But using 10 injury-associated transcripts, they came up with 5 archetypes of injury. So after we define rejection and injury, then we have to move and see, okay, what is the clinical outcome if I have this kind of archetypes of injury and rejection, how this is going to serve my clinical practice. So this is the molecular archetypes, and this is the number of rejections. And what we did see that by molecular archetypes we have 7 rejections, and the most of them, 48% was normal. You have minor rejection, which is 24.1%. And minor rejection means that the genes are there for both ABMR and TCMR, but are not expressing, as I said, sufficiently to have the diagnosis. In the early antibody-mediated rejection, it's only 3.9%. And this early antibody-mediated rejection is less intense. It's associated with parenchymal injury. Full antibody-mediated rejection was higher, 16%. And this is associated with late fibrosis, reduced ejection fraction. TCMR1, it's associated with early injury, and TCMR2 is late, and is associated with also decreased ejection fraction. And the mixed one is associated with high donor-specific antibodies. So I have to clarify that TCMR1 doesn't mean acute cellular rejection grade 1, or TCMR2, acute cellular rejection grade 2, like in histology. These are molecular microscopy rejection definitions. When we associate the molecular rejection archetypes with the histology, we found out that MMDx diagnosed a higher number of non-rejections than the histology. We know that the inter-observer variability for diagnosing T-cell mediated rejection is higher among pathologists, but as you see, MMDx have a lower number of these T-cell mediated rejection. But what was very interesting for me was that this antibody-mediated rejection by histology is mixed with a higher number of molecular microscopy diagnosis of antibody-mediated rejection. And if we look at rejection archetypes versus injury archetypes. In the cohort of no rejection, you have actually injury patterns, right? Like mild recent, like severe recent, which is the yellow, and late fibrosis. In TCMR1, you are going to have very recent injury, and this is probably correlates that I told you before, either donor-related from brain death or modes of preservation of the heart and reperfusion injury. But when you go higher, you see that the more advanced your rejections are, the more late fibrosis you are going to encounter. Which, as I mentioned, this is correlating with graft dysfunction of the low ejection fraction. This is how the report for injury is going to be done. You have different kind of colors with different kind of nomenclature, and this is PC2 over PC1 variants. And also what I want to draw attention here that the first is for all biopsies, like 3,200 biopsies. And we can see that early rejection occurs at a median time of 65 days and late fibrosis at the median time of like 3 years or so. But if you look at the biopsies in the second graph that did not have rejection, we have all of these patterns with early rejection and mild recent injury, early injury and mild recent injury that occurred very early post-transplant, and almost 4 years later, as the median time, we're going to have late fibrosis. So in other words, these hearts are not normal from the beginning until the end, even you don't have rejection. You have this injury pattern that is evolving from severe recent rejection to late atrophy and fibrosis. This is how the new reports are going to come in terms of rejection patterns and injury patterns. What about outcome, survival post-biopsy? And I'm going to start from D to A. If you look at D, this is histology. And for all your histological rejection and injury, there is no statistical significance in survival at 3 years. These are injury patterns with no rejection. And the more powerful determinant of survival at 3 years was severe recent rejection. These are injury in all biopsies, including rejection and non-rejection. I can see the same similarity. And if you look at the rejections here, the T-cell MR1 that is associated with severe injury has the lowest survival. So what we are doing with this data? We have cell-free DNA on the other side. We have molecular microscopy on the other side. If I do have negative biopsy and I have severe recent injury, but what is going to be reported to me, and late atrophy fibrosis, I'm going to do an echo and I'm going to look at LV or RV, global strain. I'm going to look at cardiac MRI. Do I treat this patient like in chemotherapy with global ocean strain that is abnormal and heart function normal? If the MRI showing fibrosis, do I start guide-directed medical therapy? This is something that we have a lot of information, but still we have to know how to translate this in our clinical practice and in our therapy for these patients. These are our data from our patients, the patient who has a histology positive for antibody-mediated rejection. By MMDx, we have antibody-mediated rejection plus injury pattern. And we treated this patient for 2 weeks. And then after 2 weeks, we have improvement in the first component, and then practically rotate it is 90 degrees, and therefore we have from top to down. But when you rotate it 90 degrees in the PC2 to PC3 component, you can see that there is still lingering some antibody-mediated rejection, even there is improvement. The histology rate is normal. So what we are doing in this situation, practically we keep more immunosuppression, longer period of time, and so on. So this is our biopsy schedule. I'm down to 3 biopsies per year, and now I'm adding MMDx for each biopsy for surveillance. At week 8, I move to cardiac. I don't use Natera yet. And for biopsy for a cause, I'm using MDx for all the biopsies. So with MTM's conclusion, MMDx enables the separate identification of rejection and injury, allowing for more tailored treatment strategies, provide a continuum spectrum between injury and rejection rather than binary results, outperform histology, distinguish better the T-cell mediated rejection compared to histology, and sometimes we are raising the question if it's okay to do biopsy so early post-transplant because they're going to be red T-cell mediated rejection with their injury pattern. And I did not show the trifecta heart trial, but MMDx correlates stronger with donor-derived cell-free DNA and less so with traditional histology. Moving towards donation after circulatory death, we know there is a discrepancy, an imbalance between the donor pool and recipient demand. And there is estimated 150,000 patients per year that are progressing to stage D heart failure. And in 2024, we performed only 4,500 heart transplants. And we've done a lot of good work in increasing donor pool by, looking at the extending criteria. We can take now donors with some LVH, with minor coronary artery disease, older donors. We've done good with accepting donors with hepatitis C. We implemented all these preservation and transport tools like Sherpa Pack and Organ Care System, OCS. And recently, now we are implementing donation after circulatory death, and we compare the outcome with donation after brain death. And when I think of donation after circulatory death, I think at 2 categories. This is donation after direct procurement and perfusion, and this is the third dose done in the United States, with the OCS as the preservation and transport method. And then donation after circulatory death using thoracoabdominal normal thermic regional perfusion. And when we started NYU, the program, we started with co-location of the donor and recipient on the same hospital, the same OR, and they reanimated the heart by bypass. Now, based on the data of Vanderbilt, patients have to go outside and to take the heart by reanimation through via ECMO, and particularly Vanderbilt transported his heart on a study called medium, like in ice, but now it's Sherpa Pack, it's more and more transported in Sherpa Pack. And Marianne-Urbana, Nebraska is traveling longer, and Sherpa Pack now has advantages of taking hearts the longer distances. And we don't know Sherpa Pack versus OCS, which one is better. It's using OCS to bring these hearts back. I started the program at NBI in January 2024 with Margarita Camacho. We've done so far 28 heart transplants, 18 brain death and 10 DCD, 7 NRP, and 3 donor procurement and perfusion. Multiple articles we published about this co-location and what was the workflow for these patients, which is normal regional perfusion. Again, we haven't done, now they are starting to do OCS at NYU. But at the beginning, we've done only NRP. And what are the advantages and disadvantages of each modality? It says that in the donation after brain death, you have the catecholamine surge that is not in DCD, DPT, but in the normal thermic perfusion, the first thing you are doing after you declare death of the patient is to ligate the carotid arteries. So we don't know by ligating these carotid arteries what is the catecholamine surge and how this is affecting the myocyte. Another thing is that with brain donation, you can assess the donor heart in situ, that you are not going to do it donation after procurement and preservation, and you are based on coronary flow dossiers, on how the heart is looking, and on lactate. But this is not true with NRP, because with NRP, since you are reanimating the heart, you can use a T probe or an epicardial echo probe to assess the heart function. With brain dead, you have a limited donor pool. With DCD, you increase the donor pool. Important, I'm going to show some data. There is no difference in survival at 1 year and 5 years between DCD and brain dead and DCD. And with NRP, you have this ethical issue of ligating the carotid arteries. I'm not going to go into much detail about the DCDs with NRP and DPP. What is important to look up is that in both NRP and DPP have this orm functional time, which usually should be less than 30 minutes in order to prevent severe primary graft dysfunction. And not with the used Sherpa pack and OCS, incidence of primary graft dysfunction was reduced considerably. So after we published the collocation, a lot of other studies came out. And this is the study from Papworth, and they have the longer duration of DCD donation. And this is comparison at 5 years, DCD with brain dead donation. And there is no statistical difference. But when you compare the NRP with the donation of procurement, direct procurement and perfusion, the survival of NRP at 5 years is 100%. Why? You have a control setting, you assess the heart in situ. So there is lots of advantage with NRP. In New York City, NRP was done at, only at NYU. None of the other centers are doing NRP because of the ethical considerations. NBI are doing both. These are data from the SRTR, so our data is from the United States, collecting from 2019 to 2021, and looking at survival at 1 year between NRP in red and DPP in blue. And this is unmatched population, no statistical significance. This is matched population, and you can see, even though it's not statistical significant, you can see a favorable trend towards NRP. These are 1 year data from Vanderbilt. They use more NRP and static, static storage, 2 cases of OCS, and they are similar to the data we got at NYU. The same survival between DCD and donation after brain death at 1 year. No difference in graft dysfunction, no difference in rejection, no difference in cardiac allogravasculopathy, everything is at 1 year, and no difference in hospitalization. So DCD is emerging like a reliable alternative for organ donation. So in conclusion, DCD organ transplantation is increasingly accepted and integrated into clinical practice across the United States. Outcomes for DCD transplantations are non-inferior to a donor after brain death, supporting the clinical viability of DCD organ. There is a suggestion that long-term outcomes favor DCD and RP, and growing acceptance of DCD reflects a paradigm shift in transplant strategies, highlighting broader utilization and confidence in DCD organs. So paradigm change in rejection surveillance are ready for non-invasive testing to take over myocardial biopsy as screening for rejection. We are indeed nearing a paradigm shift. A role of machine learning in rejection diagnostic, I think, is important. It's not only with molecular microscopy, but also by clustering histology patterns in order to diagnose rejection, the same kind of concept like in radiology that now the AI is used routinely. DCD heart transplantation is becoming the standard practice in heart transplant centers. And I didn't talk about xenotransplantation because there are still many things to be done in terms of gene manipulation, the targeting of immunotherapy, organ compatibility, and of course, infection control. Thank you, and I'm happy to take any questions.
Thank you so much, Dr. Gide, for this very detailed, very well-referenced presentation. The floor is open for questions. I will probably start. As you mentioned, molecular microscopy diagnoses injury as a separate entity from rejection. How do you approach it in terms of management?
As I mentioned, it's not very clear how to approach this. If I see injury, probably it's going to be triggered either at the echo with global strain or cardiac MRI. And if the biopsy is not showing me rejection, then it's more difficult for me to trigger this, particularly the ejection fraction both by cardiac MRI and by echo are normal. What probably I'm going to do, I'm going to survey these patients more frequently in terms of imaging and in terms of cell-free DNA than usually surveillance at a particular time.
Thank you. Another question, can we treat donor cell-free DNA in rejection as troponin in acute coronary syndrome?
Well, this is an interesting question. I think the cell-free DNA should confirm that we have rejection, because if we have coming from cardiac allograft vasculopathy, we have a different kind of therapy. So cell-free DNA is giving me wide differential diagnosis about injury, but is not correlated particularly only with rejection. If I'll have the dual testing that I saw with rejection, then yes, I can say we treat as high troponin or we act as high troponin in ST elevation MI or acute coronary syndrome. But I think we have to be careful how we interpret the cell-free DNA related only to rejection.
Thank you. I see Dr. Ahmed has raised hand.
Yes. Can you hear me?
Yes.
Okay. Thank you so much. It was a great talk. I really enjoyed it. Thank you so much for that. I have a question that, when, over a month ago, I was invited for a visit at Stanford Cardiovascular Institute. There I met few heart transplant, surgeons and experts, including Dr. Kiran Kush. I'm not sure if you have heard of her. So, when we had a discussion, that one of the problems we discussed, and that was related that she mentioned that a lot of time, donor is available, and when this heart transplant happened, there are a lot of problems or complications happen post-transplant, and because of the mismatch. So there are a lot of factors, which happens, like, some patients die sooner after the transplant. Some patients could die, a month later to that. So the question is about that, to find out those biomarkers, like genetic biomarkers, which can be very helpful to find out the compatible donor for the patient, right? So if we do this kind of analysis, which involves genetics, right, it takes a lot of time, right? So we have a very less time when a donor is available for a patient. So how can you think this timeline be reduced, and we can, improve the mechanism of finding a right donor for the patient?
So when you refer to mismatch, you refer to HLA mismatched? like to antibody mismatch when you refer that, the donors, the recipients can die because of mismatch or other kind of mismatch like, size mismatch and because it's very difficult. I mean, HLA mismatch is very well done in kidney transplant. They can cross not only a couple of antibodies, they can cross a lot of antibodies. We have methods if we take these HLA mismatch hearts to diminish the incidence of graft dysfunction and rejection, but we are staying away from profound HLA mismatch in heart transplantation. And to answer your question about genetics, I think more has to be done on the donor side. I think we still don't have a lot of donor studies in terms of getting molecular genetics matched.
Thank you. More questions from the conference room or from online audience?
Yeah. Good evening, Dr. Giria. That was a fantastic presentation. I'm really excited because I know you were instrumental in really being part of the growth of the DCD heart program at NYU and now at BI. So from implementation standpoint, some tips and some of the challenges that you faced. And again, a little comment on how regional normothermic perfusion is not allowed in all the states. So what are your comments on that?
Yeah, let me start with the last one. So normal regional perfusion started in England, and now because they have the same kind of ethical issues that there are in the United States, they suspended the program. Australia also started this program and they are still going. I think it's state differences in how you approach this normal regional perfusion from ethics point of view. If you go to Colombia, they're going to have their ethic person who is coming and gives a talk, and this is the worst thing possible. If you go to NYU, and I brought a guy from NYU at NBI and give a talk about this, this is going to be very feasible. So I think it's selective, state selective, and hospital selective. In terms of the implementation of the program, now many advances were made with the DCD donation. I think the best thing that could have happened is these companies that are going and doing the heart for us. When we started at NYU, we did co-location, and then they built a very sophisticated ECMO machine to go and take the heart from outside. But now we have these companies that are doing the work for us, and it's much easier from a logistics point of view to hire these companies, and then they deliver the heart to you. And for the DPP, you have the Transmedics with the OCS, and we have a contract with them.
That's great. Thank you so much.
Thank you.
More questions, please. Comments, opinions? I don't see any hands raised. Please feel free to speak up in case I don't see you, because there were like 60 people online listening. If no, then thank you, Claudia. Thank you, Dr. Giria, very much once again, and this concludes our panel.
Thank you for having me here.